And that day really cemented our relationship. When we started, I started just doing research on FOXG1 syndrome, getting lots of scientific documents. I didn't understand them. My neurologist didn't care about me. So I started emailing Elli, and she emailed me back, and we began this correspondence. And she has been here since day one, started the foundation with us, leads our clinical strategy, has also joined me in Citizen, which is the natural history platform that we both built, and is just an incredible, innovative, compassionate person who's leading this work. Many of you have done the interviews with her and Kopika for our disease concept model. Thank you very much. That is so informative. Kopika is also a genetic counselor. Genetic counselors are the best people on earth, by the way. Just hands down, the smartest, most caring, compassionate people in the medical industry. And Kopika has been working with us now for 2 years, doing a lot of work across many different data issues, and helping us really define understanding our symptoms. Understanding our patients' symptoms is critical. A huge reason clinical trials fail, so companies invest hundreds of millions of dollars and their clinical trial fails because they don't select the right endpoint, which we will go through why that's so important. So all of this work, when we are pushing you guys to join the registry, join the natural history study, do interviews, it's because we really need to understand symptoms, so we're measuring the right thing in clinical trials. And also so we can all understand, what is this disease? There's nothing really known out there. So with that, would love for you guys to both come up.
And measuring the outcomes. But there's also a post-market setting, which, as we've emphasized this morning, our goal is to create a therapy that's widely accessible to anyone in the world with FOXG1 syndrome. And our data strategy doesn't just stop at this phase. So where we are right now in the preclinical stage is we're really leveraging all of the data that you've contributed to design the best possible clinical trial, because we want that trial to be successful. We don't want to lose any time. In terms of the clinical trial itself, something else we want to consider is that we need to be innovative and thoughtful in how we develop and design the trial. And so we need to bring really good evidence to the FDA and other agencies across the world that provide strong rationale for why we've made the decisions that we've made, so that we can continue to move quickly. And then lastly, once that drug is available, clinical phase where we will provide treatments to humans. And really our thesis or our mission or our approach and how we've approached the clinical data strategy is, how do we best prepare when we're aiming to expedite timelines and also use a more innovative clinical trial design? And this kind of leads us to 2 clinical studies that many of you have participated in, which we're endlessly grateful for. And again, this is kind of what are the right, our primary aim here is, how can we best understand FOXG1 syndrome to measure and define the right symptoms to lead to a more successful clinical trial. So those 2 studies are, first, our natural history study, which is complementing and supplementing some other work that's been done in the Rett syndrome community. And the goal with a natural history study is really to understand what are the signs, symptoms, and experiences of FOXG1 syndrome, and how do those change over the course of someone's life. But we wanted to complement that because this kind of gives us a really rich, comprehensive data source, but we needed to make sure that we understood what that means for people living with FOXG1 day to day. And so with Kopika's help, we've launched our disease concept model study. And these are a series of interviews and other methodologies that she'll discuss, where we work to understand what are the symptoms that parents and patients care about, and what are the impacts of those symptoms on your life, and what is most important to you as a parent or patient. So with all of this combined, we kind of had a few things that we wanted to keep in mind. So one is we move with urgency. So how can we be effective and efficient in our time? How can we reduce the asks and burdens on patients and caregivers? Because we know that you really don't have time for this, and yet you show up and help us. So how can we be respectful of that? And then lastly, how do we be conscious of timelines and how much money we're spending, because we have a lot that we want to accomplish and limited resources and time. So I'm going to start talking about the natural history study and the approach that we've taken, because we have a lot of slides. I was very excited. Is we're going to try to weave in the two stories together and hope that that makes it a little bit more exciting for everyone. So this is just a quick overview of the natural history study that we started. We received our grant from Chan Zuckerberg Initiative in late 2020, and by January of 2021, we'd enrolled our first 50 patients, and by the end of 2021, we'd enrolled 100 patients. And what we performed during that study is a series of assessments over the course of 2 years. So at baseline, we leveraged our citizen platform to collect medical records and to systematically extract and code the data that's already living in medical records. And then an overview of the amount of data that we were able to generate in this 2-year study. So if you look at this chart here, on the y-axis, this represents the number of individual data points for a single individual, and then this is their age in years. So we can see that this individual is about 5.5. And the reason why I'm showing this particular patient is they represent the middle of our cohort. So about half of the patients had less data than this, and half of the patients had more data than this. And so this number, you can see, reaches almost 400 unique data points just from the medical records alone. And then when we layer in the survey data that was completed, we can see that we're surpassing that 400 mark. So most patients in this study had more than 400 unique data points collected, which is incredible. So who made up this first data cut? One thing I do want to mention, and as we kind of pointed out in that post-market setting at the beginning of our clinical data strategy, is that we're going to continue to collect data over time. This really represents our first data cut to help enable the work that Guy is leading. And so who made up this population? We looked at 101 individuals with a confirmed diagnosis of FOXG1 syndrome. About half of those individuals had frameshift variants, about a quarter had nonsense variants, and about a fifth had missense variants. So we had a good representation of the different genetic contributions to FOXG1 syndrome. And then there were just a few other points that I wanted to make. One is that when we look at the amount of data per participant, our median, so again, that halfway point, was 6 years of data, and it spanned about half a year all the way up to 34 years of data in the oldest individual. And then again, when we look at the number of data points that were annotated, our median number was 375, but you can see that it went all the way up to almost 1,500 data points in one individual. So just to kind of kick us off, we first wanted to say if we needed to kind of map out what is FOXG1 syndrome based on this data that we've generated through this study, let's look at the most common symptoms. So we looked at all of the unique symptoms that were described in at least half of the participants, and then we ordered them by when they would appear. So again, on this x-axis here is the age, and we can see that in early life, some of the first symptoms that are presenting are developmental differences, gastroesophageal reflux, I can't see, strabismus, which is when there's misalignment of the eyes, and then low muscle tone followed by feeding problems. And then we can see some other common symptoms that emerged later were epilepsy or seizures, constipation, movement disorder, sleep problems, and then some drooling or excess salivation. All right, Kopika's going to introduce our disease concept model study now.
So I'll be presenting on the disease concept model, and I'm really excited to be here and have the opportunity to share these results with you. They are preliminary results, but I do want to thank everyone who's been a part of this study and all the families who have taken the time to sit with me to do the interviews. So for this disease concept model, we're using 4 different streams of data to create the model, starting with a literature review, followed by a social media review, interviews, and a group concept activity. So the social media review is reviewing posts by caregivers in forums or through their social media posts to have a better understanding of their lived experiences with FOXG1 syndrome. So these are posts that have been written by themselves and essentially provide us with a narrative of their own experiences. Concurrently, we were conducting caregiver interviews to discuss symptom impact and caregiver impact. So these were semi-structured interviews where I would ask questions to caregivers and they would provide answers, and we would explore everything from symptoms, symptom impact, and caregiver impact. And following that, we'll be conducting a group concept activity. And this is gathering structured prompts and responses to visualize the priorities that caregivers have in terms of impacts to a child and impact to their own life. So all of these data sources will be used to create the comprehensive disease concept model. So I'll start off by discussing a little bit more about the characteristics of the individuals who have participated in the study. We had about 16 caregivers sit down with me for an interview, and the median age of our caregivers was 42.5 years. We had about 80% of our caregivers who were females, and then about 20% of our caregivers who were male. A significant portion of our caregivers were from the US, comprising for about 80% of our participants, and then the remainder 20% included individuals from Africa, Europe, and Oceania. In terms of race, we had about 75% of our respondents identify as European/white, and then 12% identify as Asian, Asian American, or Pacific Islander, and 12% identify as Black or African American. And then for the characteristics of our cohort, we had 17 individuals with FOXG1 syndrome who were part of this study. The median age was 9.8 years, and the youngest individual was about 1 year old, and the oldest individual was about 33 years old. We had about an equal split between female and male participants. And with regards to variant type, we had about 60% of our individuals who had a frame shift mutation, and then 20% who had nonsense mutation, followed by missense, gene deletion, and intragenic deletion. So this is a heat map that shows some of the more commonly reported symptoms by caregivers that came up in the interview. I do want to call out that the rows in this heat map are split up by age groups. We have under 15 years of age, 15 plus, and the bottom row is all of the data across age groups compiled together. And then for the columns, we have the symptoms. So as you can see, we have communication impairment, gross motor impairment, epilepsy, sleep symptoms, and etc. Lastly, the cell values represent the frequency of how often those symptoms were reported by caregivers in their interviews. So as you can see, the left side of the map is darker in color, which means that somewhere between 80% or 100% of caregivers had reported that interview. And as we move down this map, we see that some symptoms were less frequently reported by caregivers. So this is not dissimilar from the NHS data, because we do see a lot of the similar symptoms being reported, such as communication impairment, gross motor impairment, epilepsy. I do want to bring attention to 2 symptoms that didn't necessarily come up in the NHS data, and that's first, comprehension intactness, which a lot of caregivers had explained that they felt their child had the comprehension intact. And secondly, happy demeanor. So having that kind of data where caregivers share with us what symptoms that they see day to day and the impact that has on their child and on their life is incredibly helpful.
All right, so moving on, we're going to split our data to talk about FOXG1 syndrome in specific domains. So first, we're going to talk a little bit about some of the developmental differences that we've observed in the data that we collected. And so for each of the domains, just to orient you, I made this chart here where we measure the frequency of that symptom in the medical records, and then split that up by the 3 genotypes where we had a good number of individuals, and then this last bar here represents all of the participants of the study. So we can see here that developmental differences were reported for every participant. And this is something that we know from the literature as well, but there haven't necessarily been comprehensive or systematic characterizations of what that means. So we did a number of different approaches to better characterize developmental differences in FOXG1 syndrome. And first we looked at different milestones. So for gross motor milestones, these are some of the functions that rely on the larger muscle groups in your body, so things like sitting or walking. This chart is showing the age and frequency at which different gross motor milestones were acquired. And so that we can see on this chart here, about 70% of individuals were able to roll, about 43% were able to sit, and about a quarter were able to walk. And then this column here shows the median age and the range at which those milestones were achieved. We also administered the gross motor function classification scale to understand kind of the level of overall functioning. These are measures that are commonly used in conditions like cerebral palsy. And so the chart on the right here, or I guess the left, sorry, is looking at the average scores, or all of the scores for the gross motor function classification system, again, broken apart by genotype. And then this chart is showing how those scores changed over time, because if you'll remember, we administered this multiple times over the course of 2 years, and so we can see that scores remained relatively stable. So what does this actually mean? When we look at the scores that were commonly reported for the different genotypes, they correlated to individuals who are able to ambulate with limitations or using a handheld device, all the way to those individuals who require physical assistance or a powered mobility device. So I think that accurately represents the spread of capabilities that we tend to see in the FOXG1 syndrome population. For fine motor milestones, we again looked at a couple different specific milestones. One is the ability to grasp, and the second is the ability to perform hand functions. So this might include things like feeding, picking up a toy, passing a toy back and forth. And so if we look to the chart on the right here, we can see that about 83% of individuals were reported as being able to grasp in their medical records, and about half were able to perform hand functions. Using a similar measure called the manual abilities classification system, we again looked at what are the distribution of scores for these individuals and how does that change over time. So the median scores that we observed in the manual function correlated to individuals who can perform select activities if they're given enough time and supervision, up to those who require continuous support in order to participate in some fine motor tasks. And then lastly, we looked at communication. And so we wanted to represent a good spread, because feedback that we've consistently received from the community is that oftentimes receptive language, or our ability to understand language, is stronger than our ability to express or communicate. And we wanted to make sure that we were also capturing nonverbal communication strategies as well. So we looked at the ability to vocalize, the ability to use at least one word, whether that was verbal or nonverbal, the ability to use nonverbal communication. So this typically represented someone who might be using an AAC device or another mechanism, and then the ability to use verbal communication. And so again, if we go to the chart on the right, everyone was reported as being able to vocalize or to make sounds. About half were reported to have at least one word. About 88% used some mechanism of nonverbal communication, which I think continues to be really important as you advocate for services and support for your children. And then a smaller proportion, about 6%, were reported as having verbal communication, so communicating verbally. And then lastly, just looking again at another survey that the families completed, communication function classification system. What was striking about this is we saw relatively consistent scores independent of what genotype individuals had. And the median scores here really corresponded to individuals who don't communicate consistently with familiar partners. So that might be like caregivers, teachers, friends at school.
So as Ellie mentioned, we'll be supplementing the NHS data with data from the disease concept model. So here we have another heat map with developmental milestones that were brought up in their interviews. So with regards to communication impairment, gross motor impairment, and fine motor impairment, we found that these were consistently brought up by our caregivers, with communication impairment being brought up by all of our caregivers across the age groups. We thought it'd be helpful to supplement this data with quotes directly from their interview, so I'll be reading out some of these to you. We find that these quotes exemplify the desire or motivation for these children to move or motivation to have more interaction with their environment. So one caregiver said, he wants to do more than he physically is capable of doing. Another caregiver said, she wants to grab things, she wants to reach out to us. She wants to be able to grab her toy and pass it hand to hand, but she can't. And finally, another caregiver said, our biggest challenge is communication and really making sure that he can interact with this world in different ways. It'll never be probably independently, but we can get the communication better. It opens up much more of his world than he can currently access.
So just a quick overview. We're thinking very carefully about using development as one of our endpoints or something that we would measure in our gene therapy clinical trial. And that's because not only is this consistently described by caregivers as being important, and we see it in the medical records as being frequent in many individuals with FOXG1 syndrome, but we know that a lot of these actually have secondary impacts to other important parts of life. So, for example, gross motor impairments can impact your ability to transfer or your ability to play. Fine motor impairments will impact things like feeding, dressing, your ability to communicate using alternative communication strategies. So these are things that we want to be really thoughtful about in defining when and how we measure them in a clinical trial. So just quickly to talk about behavioral phenotypes, we were curious if there's a specific behavioral profile that's associated with FOXG1 syndrome. And so again, on the left hand here, we're looking at the frequency that behavioral challenges were reported in the medical records. And something that we can see here is that individuals with missense variants had higher frequencies of behavioral challenges reported compared to some of the other genotypes. And when we looked specifically at what was being described, terms like self-injurious behaviors, problems behaviors, aggressive behaviors were some of the terms that were being described by parents in the medical records. We also administered a survey called the Aberrant Behavior Checklist in order to kind of officially characterize behavior. This is commonly used in other neurodevelopmental disorders. And so we're looking at a few different domains that were kind of interesting to us. The first here is irritability, which is actually a domain that's pretty commonly used in clinical trials that look at behavior. And something that we see quite strikingly here is that these different dots represent the different scores that each of the individuals who participated reported, and the higher score means that you're reporting behaviors that are more associated with that particular behavior. So higher scores essentially mean that you have more features of irritability. And so we can see here that individuals with missense variants had higher scores associated with irritability. And then if we look at the bottom here, which is social withdrawal, we can see that this is a little bit more consistent across the genotypes. And then we have a quote here that Kopika will share from the disease concept model that talked about some of the behaviors.
You know, it would be great to say, can you go to a school dance? We have what's called the Boys and Girls Club here. It's a social setting. I can't let him go to that unless there's an adult with him, because there always has to be someone with him that can read and be responsive to those nonverbal cues and know when to pull him back and give him a break, because he does not have those self-regulation skills on his own.
We also looked at two other domains here. The first one here is stereotypic behaviors, which were relatively consistent and higher scores across all genotypes. And then at the bottom here, we were looking at hyperactivity or noncompliance. And again, here we're seeing higher scores, so more frequent behaviors associated with participants who had missense variants. And so, what does this mean? Kind of where we landed on this is individuals with missense variants tended to score higher on the irritability domain, which can include things like tantrums and crying, and then also on this hyperactivity and noncompliance domain, which can include features like feeling restless, being distractible or uncooperative. And then we were interested in how does this compare to other neurodevelopmental disorders beyond FOXG1 syndrome, and what we found is that individuals with FOXG1 syndrome had higher scores for stereotypies, social withdrawal, and irritability, but compared to Angelman syndrome, for example, had lower scores for hyperactivity and noncompliance. So we'll be very curious to hear from everyone later today if this kind of makes sense or if you feel that this is representative of your experience as well. Okay. So moving on to movement disorder, FOXG1 syndrome is associated with what we would call a hyperkinetic dyskinetic movement disorder. So a lot of extra movements. You might have heard terms like dystonia, choreoathetosis, and also some of movements that are affecting the mouth and the tongue. So again, if we go back to our bar chart over here, we can see that movement disorder is described in the medical records pretty consistently across genotypes and in more than 80% of individuals. And then some other, I just pulled some data here from other studies, including one that looked at video examination of movement disorder, and these were some of the features that were described. And importantly, also in that study, the authors talked about how parents all described that movement disorder had a broader impact on other parts of life. So things like toileting, dressing, sleeping, learning, being able to use nonverbal communication. So this is another clinical domain that we're interested in potentially measuring in a clinical trial for FOXG1.
To supplement that, we also found in the interviews that parents were consistently describing uncontrolled movements and movement disorders as a common phenotype or symptom that they were seeing with their children. One of the parents had said, but her movements, make it impossible. Same goes with sleep also, like when she's trying to fall asleep or stay asleep. Even after some effort, if she does fall asleep, her involuntary movements are a challenge because they would wake her up, it would wake her up. We also want to understand how movement disorders were impacting other parts of the child's life. And so you can see in the heat map that's on the lower right side of the slide, we see that movement disorder or uncontrolled movements have had an impact on the functional hand use for a child, as well as impact on AAC device use. One parent had said, one limiting factor would be more precise control of her hands and arms, to touch a screen. That would limit her communication abilities. She's always going in that direction, but it's always such a hit or miss. When we're talking about switches or the iPad, there's just no precise movements.
Okay, so epilepsy. I think a common theme that you may have heard and you'll continue to hear today is that epilepsy and FOXG1 syndrome looks really different person to person. So we see variability in when epilepsy starts, what types of seizures are reported, and how well those seizures respond to medication. So in this particular study, when we looked at all of our participants, epilepsy was present in about 70% of individuals, and those with missense variants had lower frequencies of seizures. The mean age of onset was about 2 years of age, but it ranged from very early in life up to 10 years of age, and consistent with what has been previously reported for FOXG1 syndrome, there's significant variability both in the types of seizures, specific epilepsy syndromes, and findings on the EEG. And something we'll go into a little bit more is that we do see that many individuals achieve good seizure control, but that typically requires pretty complex polypharmacy or the use of multiple medications to achieve that control. And then Dr. Benke will talk about this a little bit, but there was a recent study published from the Rett Syndrome Natural History Study that looked at how caregivers ranked specific features, and in FOXG1 syndrome, seizures were ranked fairly highly by caregivers as a top concern. So this chart here is a way at looking at what is the probability that you would develop epilepsy and FOXG1 syndrome based on your age. And so each of these little ticks along this line here is an event, which could either be the onset of epilepsy or a sensor date when we have no more data for that participant. And when we look at the median line, this age of 1.7 years becomes significant because this is the age at which the probability of developing epilepsy is 50%. So prior to 1.7 years of age, the probability is higher. And then after 1.7 years of age, the probability continues to decline. So this could be useful for families who may have a younger child who's in here and understanding the likelihood of developing epilepsy. Nasha knows that I love heat maps, so heat map filled presentation here, but we'll talk quickly about what this means in the context of epilepsy. So we wanted to quantify what the burden of epilepsy looked like for families, both in terms of the number of seizures that people were having, as well as the number of unique medications that were used. So this top chart here, again, the darker colors are going to respond to a greater proportion of individuals, and then the numbers actually represent those proportions. The further up you go in rows, those numbers, so 1, 0, 1, 2, 3, 4, 5, correspond with different levels of seizure burden, with 0 meaning that you have no seizures, and 5 meaning that you have at least daily seizures, so more than 1 seizure per day. So I think encouragingly, across all ages, a lot of people are reporting that they have no seizures during that age range, or rather what's being described in the medical records is that they have no seizures. But I do want to point out that this same chart is looking at the number of unique medications that are being used for seizures, again with 0 meaning none, and 5 meaning 5 or more unique seizure medications being used in combination at that age. So we can see that even though a lot of people have really good seizure control, many people are on at least 1 seizure medication and often at least 2 seizure medications. We also see when we look at this chart here that even though many individuals have good seizure control, there's a subpopulation that continues to have relatively high seizure burden across their lifespan. And when we look to see, what do we know about those particular individuals, it wasn't being driven by genotype. But what we did see is that these individuals tended to be younger, and they also tended to have an earlier age of epilepsy onset. So those individuals who are kind of falling into these higher seizure burden buckets had an average age of seizure onset of 11 months versus 2 years of age in this older population. So we also looked at epilepsy medications coming from the medical records, and what we found, I think, is really important for us to know and for us to be talking about with the physicians who are helping to manage epilepsy and FOXG1 syndrome. So on average, we observed that each individual trialed about 5 unique seizure medications, and this was spread across 4 lines of epilepsy therapy or 4 different combinations of therapies. But this ranged all the way up to 16 unique seizure medications in one person across 12 different combinations. And when we looked at what are the total number of unique medications and medication combinations that were reported in the about 70 people that had epilepsy in the study, there were there were 173 unique combinations. And so really what we're learning from this data is that there's not a consistent treatment pattern for epilepsy and FOXG1 syndrome, which makes it really hard for us to say what is or is not working. And so this is just a Sankey diagram here, which shows the pattern of how parents are moving, or rather how patients are moving from one medication to another. And so the thicker the line, the more individuals are represented. And so we can see that at the very first line here, a lot of people are started on Keppra, which we know, and then there's some other combinations that seem to be pretty frequent. But once you start moving into that second combination, we're seeing a lot more of these really thin lines, which means that there's only 1 or 2 individuals represented by that specific combination. So very quickly, it gets very different and variable across patients.
We also found in the disease concept model interviews that parents felt that epilepsy or seizures were one of the most challenging and important symptoms for their children. And so in this chart, we can see that nearly 90% of individuals had said this was a very common symptom for them. And then below that, we can see nearly 50% of caregivers had reported that this was a very challenging symptom for them. One of the parents had said, "I would say epilepsy is the most serious, the worst aspect of the whole syndrome, because since then, we were unable to stop the seizures. I know that there are some kids with FOXG1 that did not have seizures or that are treated successfully, but we haven't managed that with her."
Okay, and lastly, we're going to talk quickly about sleep because we know that that is really important for the health of the whole family. In other studies, sleep problems have been described both in the people with FOXG1 syndrome, but also in their caregivers, which is probably not a surprise to anyone in this room. So when we look to the medical records, about 70% of individuals were described as having a sleep problem, but that's probably underrepresented because we're basing this on what actually makes it into the medical record. And about 60% of individuals were reported as using a medication to help with sleep. We looked at the Children's Sleep Habits Questionnaire, which is a systematic way to measure sleep challenges. And what typically is used is a score of 41. If you score 41 or higher, that is kind of classified as a clinically meaningful sleep problem. And if you look at this chart here, these are the average scores of average scores on this Children's Sleep Habits Questionnaire across the different genotypes. And those average scores were all above 40. So again, no surprise to anyone in this room, but most of you are probably not sleeping very well is what we're learning from this data.
And again, we had almost 90% of caregivers identify sleep problems as a as a symptom that they have seen in their child. And then also about a third of the caregivers had identified this as challenging and important to them as a symptom. One parent had said, "I think it disrupts his ability to comprehend and learn things throughout the day. He has less patience. He's more likely to become sad or irritable." Another parent had said, "He cried a lot. He would sleep and nap during the day, but at night, when the sun went down, that boy would not go to sleep. And he cried all night long, hours, rocking, soothing, singing, nothing helped. Eventually, 1, 2, 3, 4 o'clock in the morning, he would finally fall asleep."
Okay, so just a couple slides here. We've talked a lot at the last conference about this concept of genotype-phenotype correlations, meaning that what we've observed in FOXG1 syndrome is that individuals with missense variants appear to have kind of a slightly different presentation of FOXG1 syndrome compared to some of the other genotypes. And so we were kind of interested in characterizing that, but also more importantly, understanding how does FOXG1 syndrome severity as a whole change over time? Can we demonstrate to the agency and to ourselves that this is not a regressive disorder, for example? So another group of researchers and clinicians a few years ago looked at a really broad population of individuals with FOXG1 syndrome, and they made what they called a severity score that essentially looks at the different features that are common in FOXG1 syndrome. And so if you had a higher severity score, that simply meant that you had more features that are typically associated with FOXG1. So we replicated that using the medical record data, and we looked at it in two different ways. The first is just looking at scores in the first year of administration. What was sort of the spread of FOXG1 severity across the genotypes and the entire population? And similar to what the authors of this paper reported and what we've observed in other studies, individuals with FOXG1 syndrome had fewer of the features that are typically associated compared to frameshift or nonsense variants. But something that was really important to us is that when we look at severity over time, it actually remains relatively stable. And so something that we were kind of interested in is, one, can we prove this statistically? but also can we give parents and clinicians a tool for when they're seeing a young person with FOXG1 syndrome to try to predict what their FOXG1 severity might be in future. So we looked at we developed a specific model where we wanted to understand the influence of certain variables that you might know about your child early in life. So first we looked at age, as I talked about, and you can see that because this is a flat line, age all the way up to about 30 years of age did not significantly impact FOXG1 severity. So we really don't see that people are getting worse as they get older. It appears to be a relatively stable condition. We also looked at head circumference at 1 year of age, so really looking to understand if individuals who have a smaller head early in life, can that help predict whether they might have a more severe presentation in future? And this did not achieve statistical significance, so we're not confident in this data that it's, fully causative, but we do see a trend where if you had a smaller head circumference at 1 year of age, you tended to have a higher seizure severity, a higher FOXG1 severity score over time compared to those who had a larger head circumference. And then we also looked at epilepsy age of onset to try to understand if the age at which you start having seizures can predict overall FOXG1 severity. And we see a more moderate line here where younger age of onset tends to be associated with higher severity scores over time compared to those with an older age of onset. But again, this was not significant, so it's kind of like a trend or an observation that we're keeping an eye on. And in fact, the only thing that statistically significantly was associated with FOXG1 severity over time was whether you had a missense variant or not, which continues to be kind of interesting for us to think about. So we kind of wanted to conclude our presentation by talking a little bit about the caregiver experience. So I'll hand it over to Kopika.
So we spent a lot of time today talking about symptoms, symptom impact, and the impact that has on the life of a child. But one of our goals with the disease concept model was to learn more about the caregiver impact and experience for caring for a child with FOXG1 syndrome. So as a part of this disease concept model, our interviews included questions to help document their caregivers' lived experiences that have not been well characterized in literature. And a number of themes arose during those conversations. We saw that almost all caregivers described fear, which includes fear of the future or fear of the unknown, impact their work, acting as an advocate for their child, isolation, lack of agency or independence as a part of their caregiver experience. So again, you can see that on the left side of the heat map where we're seeing the darker squares or the more pigmented cells there. We also see that some impacts of the caregiver, such as vigilance and home modifications, were referenced at a slightly higher rate for caregivers with children over the age of 15. So you'll see that on the right side of the slide there. So I'll dive a little bit deeper into this caregiver experiences by sharing some of the quotes that came out of our interviews. So as I mentioned, one of the themes that came up was fear. So fear of the unknown or fear for the future. One of the parents said, "We are getting older and faster than we thought, just because of the physical demands. So really just planning for her future. What is that going to look like what's going to happen if we're not here or if we're not able to care for her?" Following that, another theme that came up with a lot of the caregivers was advocacy. So acting as an advocate for your child. One parent said, "But I'll be honest with you, most of my stress where she's concerned is not her, it's her providers. It's not my child. It's the help that she needs or the people that she has to interact with that don't do what's right. That's where my stress comes from. When I have to be on a phone with providers negotiating a wheelchair for my child, those are the things. It's the outside world that can be a problem. When I'm on the phone with an airplane trying to get accommodation for her, or the interaction about people not being accommodating, that's a problem. It's other people, it's not my child. It's the help that she needs or the support that she should be provided that becomes a source of stress for me." Another common theme that came up was isolation. This includes isolation socially, but also lack of agency or lack of independence as a caregiver. It's kind of like I can't walk off my front porch unless I've got somebody's permission, either the state's permission or a doctor's permission or somebody's permission so I can leave. My life is totally controlled by other people making decisions for him that impact us. And lastly, as I mentioned, vigilance was a common theme as well. A parent had said, the stress of having to always be totally and fully engaged and prepared for a possible negative outcome at any moment is very high, and that is taxing on your general well-being.
Okay. Thank you all for your attention, and we really hope that that was helpful. And as mentioned, please feel free to come up to us and ask questions over the next couple of days. So we're just going to take a couple minutes to kind of summarize what does this all mean. So as I mentioned, really the goal of these research efforts are to make sure that we can optimize how we design a clinical trial. And so given all of those different clinical domains that we talked about, what we're really interested in determining is what is the overlap between symptoms that are common, things that are important to you, and things that we can measure well. And so when we look at the totality of data, we're starting to get an understanding of where we think we're going to go for the clinical trial. So we're thinking that our priority endpoints, so the most important things that we want to measure are going to be communication, gross and fine motor skills, activities of daily living, and movement disorder. But we're also interested in exploring a number of other possible outcomes that may not be the thing that determines the trial today, but we hope can establish precedents for future. And that would be things like looking at video assessments, sleep disruption, and also the use of devices to identify possible digital biomarkers. So Guy and I will be talking about that a little bit later. And again, all of this is really in the context of how do we make this leap across the chasm from preclinical to clinical. And we, as I hope is evidenced by this data today, we really could not have done it without the support and participation of this community. So we are very grateful and very excited to see what we have to report at the next family conference. So thank you, guys.
So how lucky are we to have Elli and Kopika? And I just have to say, Elli does not have a child with FOXG1 syndrome and has been donating her time doing all of this work from the beginning. After 7 years, we have finally been able to convince Elli to take a small, very small stipend. But she has been doing all of this just out of her goodwill. And thank you so much, Elli.